The adoption of the European Working Time Directive was one of the factors which, although it did not reduce the number of doctors working in the health service, certainly reduced their availability to work at any one time. This meant that more work had to be done by fewer people.
So in the out-of-hours period, doctors are on call. So what they do is they have a small team of doctors looking after a very large number of patients. Well, the patient numbers don't change, but the number of doctors in the out-of-hours period does. So we have to decide where to put these doctors in the out-of-hours period and what workload they should pick up. Deciding that has never really been fully investigated or examined, and this is part of the project.
We have 3 large corridors. We cover the majority of the inpatients aside from the intensive care areas. We generate a high volume of work out of hours. So we do have a small team overnight, and obviously the work that generates doesn't change. So the coordinator's role as well is to prioritise tasks and look through the doctor's tasks and try and reduce that workload. Often we can have quite junior doctors on a shift out of hours, so it's ensuring that we're there for support and advice, directing them to senior doctors that are on call with us when the need arises. Very challenging, but also very rewarding.
Whilst there is a general recognition in the medical profession that the workload undertaken by junior medical doctors in training is excessive, there's been no good documentation of this. In order to take this forward, the Royal College of Physicians formed the Safe Medical Staffing Working Party, and we're trying to gain evidence to support recommendations for the future.
Within WayWard, we're looking to see how we can use different types of data to more thoroughly understand the work of doctors out of hours in a hospital setting. The different types of data that we've got have different types of qualities. They intrude on the task in different ways. So it's really important that we understand what we can learn from these different sources of data and how they can help both to inform the way that hospitals are organised, but also provide really useful training resources for the future doctors who will be working in the out-of-hours context.
So each time a patient needs to see a doctor out of hours, that job is raised through an electronic task management system. It's passed to a small team of doctors working in the hospital out of hours, and it's also recorded. The details of that task are logged in a database which we can use, and it forms the core set of data for the WayWard project. Our work's discovered that the peak of tasks is happening as a result of handing over from day shifts when the hospital is fully manned but people are having to go home. Those tasks are flowing into the out-of-hours system, causing a backlog which starts at 5 and 6 o'clock in the evening on weekdays and lasts all the way through the night into the early hours of the morning.
The working hours of junior doctors are shorter, but the intensity of their work has increased. The degree to which this is a problem has never been clearly defined and documented. The WayWard project has been able to show the level of work done by doctors in training, and this has led to information being available to recommend staffing levels in the future.
So what we've had the opportunity to look at here is what we can learn from each of these individual data sets and how we can actually get the additional power by combining those data. So we've got 3 types of data. We've got the task data, we've got activity data that we've gained from observing the doctors when they're working, and we've got location data. That task data is really, really useful to us because it's very rich in terms of understanding the tasks that have been allocated. But it's got some limitations. For example, it doesn't tell us how long those tasks take. The activity data is really detailed, but it takes a really long time to collect it because it requires an expert to actually be observing a doctor while they're doing their work. And the location data is very accurate in terms of telling us about the position of a doctor while they're completing their task, but it doesn't necessarily tell us what the doctor is doing. So if we look at combining all 3 of these data sets, we can end up with a really rich picture. But in addition to this, it's not practical for us to always have someone observing a doctor while they're doing this work. So we're also able to learn how much we can actually infer about the activities that an individual is doing by just looking at the automatically generated task data and the location data, which is not intrusive in any way.
So the task management system gives us a really good idea of the quantity and the nature of tasks that are being put through the out-of-hours system. But it tells us very little about how long those tasks take, and in fact which order the individual clinicians choose to do those tasks, which is a very important part of their work. So to get at that information, we use these boxes, which give us information about the location of the clinician. So each of the jobs happen in a separate location or in a different location, and that tells us which tasks they're engaged in at any given time.
Obviously, we've had a really strong opportunity to work with our local hospitals in Nottingham. These are very large hospitals. They present real challenges actually in terms of their geography being so big. But they've also invested quite heavily in technology to support doctors in managing their out-of-hours care. So it's important for us to understand how the methods that we've applied with our colleagues in Nottingham also transfer to other types of hospitals. For example, a hospital which doesn't have the data where the tasks are automatically allocated but uses a pager-based system, or a hospital that is less teaching focused and smaller in terms of both the number of patients it handles and the number of different types of conditions that are managed within that setting.
So in Nottingham, an electronic task flow system is used, and this is a terrific source of data for us to do our studies. However, it isn't representative of the bulk of the country. Most hospitals don't have that. So for several decades now, we've been using a system of pagers and phone calls to organise the tasks out of hours.
Hello, this clinician can help you.
So if a nurse requires some assistance from a senior nurse or a clinician out of hours, they'll page the night nurse clinician, and that individual will take the responsibility for triage, but also crucially for documenting what's happened, what the task is, where it's required from, and what the outcome was. With the number of phone calls and pages that are required, there's great scope for loss of information and for delays on the day, but also for lack of insight in the long run, because that information isn't being captured in real time. It relies on somebody going back through the notes and looking at that and summarising it into charts and graphs.
If you're better informed, you can do your job better basically, can't you? We're not the biggest hospital, but we're a very busy acute hospital. There's approximately 680 beds in this hospital now, and we have predominantly one nurse clinician on duty. The great thing about Aintree is we have a medical emergency team. So I'm always reassured that in the event that somebody who's really sick, we have this emergency number that the ward staff can call out. But for those patients who perhaps aren't quite as sick, but have the potential to get that sick, if they don't get seen earlier, my worry is that people are having to wait before we can get to the bleeps to answer them.
It's remarkable, I think, to me that we have remained so behind the times with our out-of-hours services. Something which you might perceive to be more urgent and important, somebody having chest pain out of hours, we're still reliant on phone calls, pagers. With the location information, we're quite used to having location information on our mobile phones and making our own lives easier when we're navigating around town or something similar. There's no great leap from that to using location information from hospitals to understand what people are doing in the past and where the resources are presently.
The evidence already provided for the Medical Staffing Working Party by the WayWard project has been very, very helpful. But there remains an area which is unclear, and that is the workload of the medical registrar. And ironically, this is probably the most onerous task within the whole of medical training. We hope in the future that the WayWard project will be able to be extended to include this work, and that will help us enormously.